Welcome to the deep dive. Today, we are zeroing in on a topic of critical importance for specialist clinicians, the assessment and management of air or gas embolism. We are about to embark on a comprehensive exploration, meticulously extracting essential, practice-changing insights directly from a key expert source.
That is precisely our aim. The foundational source material guiding this deep dive is a truly in-depth review, specifically the chapter titled Hyperbaric Treatment of Air or Gas Embolism, Current Recommendations, authored by the highly respected Dr. Richard E. Moon and Dr. Simon J. Mitchell.
Right.
This is a seminal work in the field, packed with clinical nuance and drawing upon a vast body of research, including figures and tables that provide crucial data and algorithms we will be examining in detail.
Our mission is clear: to move beyond a surface-level understanding and truly delve into the source material. We want to pull out every crucial detail, every clinical pearl that is directly applicable to your practice. We'll be thoroughly exploring the diverse mechanisms by which air and gas can enter the circulation, the sometimes subtle, sometimes dramatic ways this condition can manifest clinically, the approach to diagnosis, and crucially, when and why conventional imaging may or may not be helpful, the absolutely critical initial management steps you must take, the definitive and indispensable role of hyperbaric oxygen therapy, various adjunctive treatments that might be considered, what the evidence tells us about expected outcomes, and a granular review of the many specific causes and clinical scenarios where this potentially devastating event can occur.
We'll structure this deep dive like a focused, high-level academic discussion, ensuring we cover the material with both thoroughness and authority. We'll begin by rigorously defining arterial gas embolism and venous gas embolism, then transition into a detailed exploration of their numerous mechanisms.
Okay.
Moving from there to the varied clinical presentations, the intricacies of the diagnostic process, including their precise role and limitations of imaging, outlining the non-negotiable immediate management steps, detailing the multiple ways hyperbaric oxygen therapy provides benefit, reviewing the evidence behind adjunctive therapies and typical outcomes, and finally, walking through a comprehensive inventory of specific causes and predisposing scenarios presented in the source.
Okay, let's unpack this complex topic. To begin, we absolutely must have precise definitions. When we talk about air or gas embolism, what are we fundamentally distinguishing between?
At its core, the distinction lies in where the gas bubbles end up within the circulatory system. We differentiate primarily between arterial gas embolism, or AGE, which is defined by the presence of gas bubbles within the arteries,
Right, the arterial side.
and venous gas embolism, or VGE, which is the presence of gas bubbles within the veins. While both involve gas in the vasculature, their immediate pathways through the body and their typical clinical consequences are quite different, though, as we'll discuss, one can certainly lead to the other.
And the causes of this are incredibly diverse, extending far beyond the diving accidents that perhaps first come to mind.
Absolutely. That's a critical point for clinicians across specialties. Let's examine the primary ways gas embolism occurs. Arterial gas embolism most commonly originates from a breach in the alveolar capillary membrane within the lungs,
Okay.
allowing gas to move from the air spaces directly into the pulmonary circulation, which then flows into the left side of the heart and out to the systemic arteries. This disruption is frequently a result of pulmonary overpressurization.
Pulmonary overpressurization, that sounds like a direct application of gas physics to lung mechanics.
It is fundamentally linked to Boyle's law. Boyle's law describes the inverse relationship between the pressure and volume of a gas when temperature and mass are held constant. As pressure decreases, volume increases.
Simple physics, but with major consequences here.
Exactly. Think about breathing compressed gas at depth, during diving or in a hyperbaric chamber. The gas you inhale is at the same elevated pressure as the surrounding environment, meaning a relatively small volume of gas contains a large number of molecules.
Okay.
As you ascend towards the surface, the ambient pressure decreases.
Yeah.
According to Boyle's law, the gas in your lungs will expand proportionally. If this expanding gas volume cannot escape freely, for instance, if a diver holds their breath, if there's pre-existing airway obstruction, or if there are structural abnormalities in the lung tissue like bullae or cysts that trap air, the pressure within the alveoli can rise dramatically.
Quite radically.
This elevated alveolar pressure can exceed the tensile strength of the delicate alveolar capillary membrane, causing it to rupture. When this rupture occurs, the high-pressure gas is forced to cross the damaged membrane and directly into the pulmonary capillaries or small pulmonary veins.
And that's the direct route to the arterial side.
Correct. Since these vessels lead directly to the left atrium, left ventricle, and then the systemic arterial circulation. The result is arterial gas embolism. This mechanism, pulmonary barotrauma during ascent after breathing compressed gas, is the classic pathway for AGE in divers.
So it's not just about breathing compressed gas at depth, but specifically about the pressure changes during ascent and the inability of gas to escape freely.
Precisely. That rapid pressure decrease during ascent is the key trigger. And it's not just divers. You can get venous gas embolism resulting from the formation of inert gas bubbles in the tissues. This typically occurs in situations involving a significant load of dissolved inert gas in the body's tissues, accumulated under higher pressure or after breathing gases with high inert gas content.
Like nitrogen from air?
Usually nitrogen, yes, followed by a rapid decrease in ambient pressure. As pressure drops, the inert gas comes out of solution in the tissues and forms bubbles, similar to how CO2 bubbles form when you open a soda can. These tissue bubbles then enter the venous circulation.
Which is decompression sickness, fundamentally.
This is the primary mechanism behind decompression sickness, but the venous bubbles formed can also contribute to gas embolism, particularly if they cross over to the arterial side, as we'll discuss.
And both AG and VGE can occur during medical procedures.
Absolutely. This is a major source of gas embolism in clinical practice. Both can occur during certain surgical and medical procedures. A key mechanism in the surgical setting is when the hydrostatic pressure within capillaries and small veins at the operative site becomes subatmospheric.
Negative pressure.
Effectively negative relative to the ambient atmospheric pressure. This frequently happens when the surgical field is positioned significantly above the level of the patient's heart. In this scenario, the lower pressure within the open vessels creates a gradient that effectively sucks or entrains air from the surgical field directly into the venous or, less commonly, arterial circulation.
That sounds like a dangerous pressure differential.
It is. And this mechanism, along with direct injection and other introductions, falls under the broad category of iatrogenic gas embolism. This term refers to gas introduced into the body inadvertently during a medical procedure, and it represents a significant proportion of the gas embolism cases seen in hospital settings.
Let's elaborate on these diverse mechanisms in more detail.
Okay, focusing first on the detailed AG mechanisms. The historical context of this phenomenon, as highlighted in the source, is linked to early submarine escape training. This involved trainees learning to escape from submerged submarines by breathing compressed air and making a free ascent to the surface. This technique, while vital for survival, is inherently a controlled, rapid breath-hold ascent after breathing compressed gas, providing a clear historical demonstration of pulmonary barotrauma leading to AG.
So pulmonary barotrauma from free ascent after breathing compressed gas at depth is the core issue in divers.
It is the classic picture. The physics and physiology are undeniable. The volume of gas trapped in the lungs expands as pressure drops during ascent. If this expansion isn't accommodated by exhalation, the pressure gradient across the alveolar wall increases until rupture occurs, forcing gas into the pulmonary capillaries or venules.
And the critical preventable behavior here is holding your breath during ascent.
That's the major, often preventable cause in healthy lungs. If a diver breathes compressed gas at depth and then holds their breath while ascending, the expanding trapped gas volume leads directly to alveolar overpressurization and rupture.
That fundamental rule of diving.
Which is why the fundamental rule of compressed gas diving is never hold your breath during ascent.
The source makes a point about the depth involved.
Yes, and it's a crucial clinical takeaway. Pulmonary barotrauma sufficient to cause gas embolism can occur from ascents from surprisingly shallow depths, as little as 1 to 2 meters.
Just 1 or 2 meters. That's very shallow.
It is. This means the risk is not consigned to deep dives. Even minor ascents, if performed incorrectly, like holding your breath after just a few feet down, carry this potential danger. It's not about the absolute depth, but the pressure change experienced and the inability of the gas to escape.
And pre-existing lung conditions make individuals more susceptible.
Absolutely. AG can occur even during a normal controlled ascent in divers who have pre-existing lung pathology. Conditions like bullous lung disease, which involves air-filled sacs within the lung tissue, or even severe asthma with air trapping.
Things that trap air.
Exactly. These conditions can create areas of the lung that are less compliant or prone to airway closure during ascent. These areas can trap gas, making them susceptible to overpressurization and rupture at pressure differentials that would not affect healthy lung tissue.
Which underscores the need for proper dive medicals.
Right. This is why a thorough medical evaluation, including lung function assessment, is important for individuals planning to breathe compressed gas underwater.
Are there other Less common, but perhaps even more severe, mechanisms involving the lungs.
The source briefly mentions that pulmonary barotrauma can also result from direct lung injury, such as that sustained during blast injury or significant underwater trauma. These events cause direct structural damage to the lung tissue and alveolar capillary membrane, creating a pathway for gas to enter the circulation. These are less common, but represent severe traumatic causes.
We've covered the pulmonary barotrauma route extensively. Let's return to the broad category of iatrogenic gas embolism. What are the specifics here?
Iatrogenic gas embolism is, as the name suggests, gas introduced into the body during medical procedures. This can be accidental intravascular injection of gas, either directly into arteries, though this is less common, or more frequently, into veins with subsequent passage to the arterial circulation.
If gas is introduced into the veins, isn't the lungs supposed to filter that out?
That's a critical protective mechanism of the pulmonary vasculature. For small volumes of venous injection, the pulmonary capillaries typically act as a highly efficient filter. They are so narrow that they trap small gas bubbles, preventing them from reaching the left side of the heart and entering the systemic arterial circulation.
So small amounts are usually okay.
This is why small volumes of venous gas embolism are often asymptomatic. The bubbles are filtered and eventually resorbed in the lungs.
But this filter can be overwhelmed.
Precisely. Large volumes of venous gas can simply overwhelm the physical capacity of the pulmonary capillary bed to trap the bubbles. When this happens, bubbles pass through the lungs, reach the left side of the heart, and are distributed into the arterial circulation, causing arterial gas embolism.
And what are the clinical consequences when large volumes of VGE overwhelm that filter or cause other issues in the pulmonary circuit?
Large volumes of venous gas embolism can lead to significant acute clinical consequences impacting cardiopulmonary function. They can cause non-cardiogenic pulmonary edema by damaging the capillary endothelium in the lungs.
Right heart strain, too.
Yes, they can lead to mechanical obstruction of blood flow within the right heart chambers or pulmonary artery, sometimes referred to as cardiac vapor lock, resulting in acute right heart strain, profound endothelial injury throughout the pulmonary vasculature, leading to widespread inflammation, significant hemodynamic instability, including severe hypotension, and respiratory symptoms such as cough and dyspnea. These are specific, severe manifestations of large volume VGE.
And then there's that fascinating and crucial mechanism where venous gas reaches the arterial side without ever going through the lungs effectively.
Yes, this is the concept of paradoxical embolism. This occurs when venous gas bubbles cross directly from the right side of the heart to the left side, bypassing the pulmonary capillary filter entirely, and are then immediately distributed into the arterial circulation.
Through a hole in the heart, essentially.
The most common pathway for this is via an atrial septal defect, or more frequently, a patent foramen oval. A patent foramen oval, or PFO, is a persistent opening between the right and left atria that represents a failure of the embryonic foramen oval to functionally close after birth.
How common is a PFO in the general population?
This is clinically relevant because PFOs are quite common. While estimates vary based on the detection method used, postmortem and echocardiographic studies suggest that a patent foramen oval is present in approximately 25% of the general population.
Wow, 1 in 4 people.
Roughly. So in the presence of venous gas bubbles and a right-to-left pressure gradient across the atrial septum, which can be transiently induced by increases in right atrial pressure, such as with coughing, straining, Valsalva maneuver, or even certain patient positions or procedures. Venous blood-containing bubbles can be shunted directly from the right atrium to the left atrium through the PFO.
And straight into the arterial system.
From the left atrium, it enters the left ventricle and is pumped into the systemic arterial circulation, leading to arterial gas embolism of venous origin. This is a vital mechanism to consider in cases of unexplained AGE, especially if known VGE has occurred or if the clinical setting suggests increased right heart pressure.
Can you have asymptomatic VGE?
Absolutely, and this is quite common, particularly in certain populations. Asymptomatic venous gas embolism is frequently observed, for example, after compressed gas diving, even when conducted within established safety limits, and also after rapid exposure to altitude.
In what kinds of specific situations might this asymptomatic VGE occur from altitude exposure?
Right. Situations include flight in a military jet, where rapid ascents are common, exposure in a hyperbaric chamber used for altitude training or simulation, or potentially even during an accidental rapid loss of cabin pressure during commercial flight, though the latter is very rare and cabin pressure is typically maintained.
And you touched earlier on VGE from passive air entry in surgical settings.
Yes, that passive entry mechanism from surgical sites needs emphasis. As we discussed, VGE can result from the passive entry of air into open veins in surgical wounds when those wounds are elevated above the level of the heart.
Creating that negative pressure again.
Exactly. In this positioning, the venous pressure at the surgical site becomes subatmospheric relative to the surrounding environment, creating a pressure gradient that literally draws ambient air into the open vessels. This is a well-recognized risk in procedures performed with a patient in a sitting or steep Trendelenburg position, among others.
Are there other more unusual mechanisms for gas embolism? The source listed oral ingestion of hydrogen peroxide?
That's a specific and clinically relevant one to be aware of. Oral ingestion of concentrated hydrogen peroxide solutions is another mechanism. Hydrogen peroxide is absorbed into the circulation and then interacts with catalase, an enzyme widely present in erythrocytes or red blood cells. This enzymatic reaction rapidly decomposes hydrogen peroxide into water and gaseous oxygen. The rapid release of a large volume of gaseous oxygen into the bloodstream results in the formation of venous gas embolism. And due to the sheer volume or passage through a shunt like a PFO, it frequently also leads to arterial gas embolism.
Returning to iatrogenic causes, what happens specifically with intra-arterial injection of gas?
Direct accidental intra-arterial injection of small volumes of gas is often surprisingly asymptomatic. This might be due to the rapid flow in arteries, which helps distribute the gas, and the ability of the distal capillary beds to filter small bubbles, or the relatively smaller volume of gas injected compared to the vascular volume.
Have studies quantified the volumes or rates that might be tolerated?
Yes. Experimental animal studies and limited human observations have provided some insight, though direct human data on bolus arterial injection is sparse for obvious ethical reasons. In experimental animals, intravenous injection of gas has been tolerated up to 0.5 to 1 milliliter per kilogram of body weight before significant hemodynamic effects occur. In humans, continuous intravenous infusion of air at a rate of 10 milliliters per minute has been reported not to cause symptoms. These findings suggest a significant capacity for the pulmonary filter to handle slow, small venous gas loads.
But bolus injections are worse?
Generally, yes. Bolus injections of gas are generally more likely to cause significant clinical abnormalities compared to the same volume infused slowly over time, both arterially and intravenously. This underscores that the rate of gas entry is critical, not just the total volume.
Let's delve deeper into the pathophysiology. How exactly do these gas bubbles injure tissues, particularly in the brain, which is so commonly affected by AGE?
The mechanisms are complex and multifaceted, going beyond just simple physical blockage. While large volumes of gas introduced into, for instance, the pulmonary veins can, in rare cases, cause mechanical obstruction of blood flow within the left side of the heart chambers, leading to acute intracardiac vapor lock with profound hypotension or acute circulatory arrest, this is less common than effects on smaller vessels.
So is physical blockage by bubbles a primary injury mechanism?
Yes, in the arterial circulation, particularly in smaller vessels like those in the brain, large bubbles can lodge in and obstruct vessels, causing immediate ischemia in the downstream vascular territories, much like an embolic stroke caused by a blood clot.
But what about smaller bubbles? The source mentions they might redistribute initially.
That's where the complexity increases. Smaller bubbles, especially in the cerebral circulation, might initially redistribute into smaller arterioles or capillaries without causing complete prolonged obstruction. However, studies, particularly elegant animal experiments, using cranial window techniques.
Looking directly at the brain vessels.
Yes, which allow direct visualization of the cerebral microcirculation, have shown that even after initial passage or redistribution of bubbles, there is a progressive decline in cerebral blood flow, observed over minutes to hours.
How does blood flow decrease if the bubble isn't permanently lodged there?
This appears to be mediated by a complex series of events triggered by the bubble's presence. One key mechanism involves neutrophils, a type of white blood cell.
The inflammatory cells.
Right. Bubble contact with the vascular endothelium, the inner lining of the blood vessels, causes stripping of the endothelial cells from the underlying basement membrane. This mechanical damage in the presence of the bubble initiates a local inflammatory response, attracting neutrophils. These activated neutrophils then adhere to the damaged endothelium and accumulate, contributing to microvascular obstruction and further impairment of blood flow over time, even after the initial bubble has moved on.
Does arterial gas embolism affect pressure within the skull?
Yes, AGE can cause intracranial hypertension and increase in pressure within the skull. This elevated intracranial pressure can further compromise cerebral blood flow, exacerbating the initial ischemic injury and contributing to overall brain damage.
The source also mentions a complex cellular injury pathway involving ion channels.
This is a more recent area of research highlighted in the source. Even without direct mechanical blockage by large bubbles, simple bubble contact with endothelial cells can trigger a cascade of events at the cellular level.
Just touching the cells.
Just the contact. It initiates the opening of specific ion channels, such as transient receptor, potential vanilloid, or TRPV ion channels. The opening of these channels leads to an influx of calcium into the endothelial cells. This increase in intracellular calcium concentration can cause mitochondrial dysfunction, disrupt cellular processes, and ultimately contribute to cell death and vascular dysfunction.
Wow, so it's not just plumbing, it's cell signaling too.
Precisely. This suggests that the injury is not purely mechanical, but also involves complex cellular signaling pathways triggered by the bubble.
This complex injury might explain something else. The source mentions initial clinical improvement followed by delayed deterioration.
Exactly. This understanding of the microvascular inflammatory and cellular injury pathways helps explain the clinical observation in some AG cases where patients experience initial clinical improvement, which might be attributed to the rapid dispersal or resorption of some bubbles, followed by a concerning delayed deterioration hours later.
What are the proposed mechanisms for this secondary deterioration?
The source proposes several mechanisms for this delayed worsening. These include the formation of cerebral edema, or brain swelling, which increases intracranial pressure and reduces blood flow. Inflammation, triggered by the initial endothelial damage and neutrophil accumulation, continues to progress. There's also the possibility of re-embolization by bubbles that were previously sequestered in an anatomic trap, such as potentially in the pulmonary veins, and are released later.
And clotting.
Secondary vessel occlusion by thrombosis or further accumulation of neutrophils at sites of prior injury can also contribute. Furthermore, impairment of cerebral blood flow autoregulation.
The brain's ability to control its own blood flow.
Correct. The brain's ability to maintain consistent blood flow despite changes in systemic blood pressure has been reported after AGE, making the brain more vulnerable to secondary insults and contributing to delayed injury.
Let's take a moment here. We've covered a lot of crucial ground on the definitions and intricate mechanisms.
We certainly have. Understanding these pathways is fundamental to recognizing and managing gas embolism effectively.
Micro recap 1. We started by defining the core terms, arterial gas embolism and venous gas embolism, based on where the gas ends up. We explored the primary causes, including pulmonary barotrauma from pressure changes during ascent after breathing compressed gas, especially with breath holding or underlying lung disease, and how this relates to Boyle's law.
We also covered venous gas embolism from tissue bubble formation during decompression, and importantly, iatrogenic causes as a major clinical source, direct injection, passive air entrainment in surgery.
Right, especially with surgical sites above the heart where venous pressure is subatmospheric. And the crucial concept of paradoxical embolism, where venous gas bypasses the lungs via PFO or ASD, noting how common PFOs are.
Don't forget hydrogen peroxide ingestion is another cause. Then we really dug into the pathophysiology, not just mechanical blockage, but significant microvascular damage, endothelial stripping, neutrophil inflammation, even cellular issues like calcium influx via TRPV channels and mitochondrial dysfunction.
Which helps explain why intracranial pressure might rise and why we sometimes see that worrying pattern of initial improvement followed by delayed deterioration due to ongoing edema, inflammation, or secondary occlusion.
That detailed look at the how and why sets the stage. Now let's pivot to what you actually see when a patient presents with gas embolism.
So what are the key signs and symptoms that should raise our suspicion for gas embolism?
The clinical presentation is highly variable and depends greatly on the volume of gas, the route of entry, and where the bubbles ultimately travel and lodge.
Let's focus first on the signs of AG manifestations, as arterial involvement, particularly cerebral, often leads to the most dramatic presentations.
When gas bubbles enter the arterial circulation and travel to critical organs, especially the brain, the manifestations can be abrupt and severe. These include sudden loss of consciousness, acute confusion, focal stroke-like neurological deficits, such as sudden weakness on one side of the body, hemiparesis, or difficulty speaking, aphasia.
Like a stroke.
Exactly like a stroke presentation, often very sudden. Other signs include impaired consciousness, ranging from lethargy to coma, seizures, and if coronary arteries are involved, cardiac arrhythmias or signs of myocardial ischemia. Because gas is highly mobile, The symptoms can sometimes be transient or waxing and waning initially.
And what about VGE manifestations?
If the venous gas load is significant enough to impede blood flow through the right heart or pulmonary circulation, or if it causes sufficient pulmonary endothelial damage, the symptoms are primarily cardiopulmonary. These can include sudden hypotension, rapid breathing tachypnea, low carbon dioxide levels in the blood, hypocapnia, due to increased ventilation.
Trying to blow off the gas.
Well, it reflects the ventilation-perfusion mismatch and dead space created. Also pulmonary edema, signs of right heart strain, and in severe cases, profound circulatory collapse or cardiac arrest.
The timing of symptom onset seems like a really important diagnostic clue, especially in divers.
It is a critical piece of information. For divers experiencing arterial gas embolism from pulmonary barotrauma, the onset of symptoms is typically very rapid, usually occurring within seconds to a few minutes of surfacing.
Seconds to minutes. Very fast.
Very fast. This rapid onset is because the gas is forced directly into the pulmonary veins and arterial system as soon as the alveolar rupture occurs during the final phase of ascent.
Can the presentation in a diver ever be confused with or overlap with decompression sickness?
Absolutely. There can be significant overlap, and sometimes it's difficult to distinguish purely. If a diver has spent sufficient time at depth breathing compressed gas, they will have accumulated a significant load of dissolved inert gas in their tissues.
Right, they could have both happening.
Exactly. The event precipitating the AGE, like a rapid ascent or breath hold, could concurrently cause decompression sickness from off-gassing of this dissolved gas. In such scenarios, the gas embolism, particularly if it affects the brain or spinal cord, can precipitate neurological manifestations that are also seen with decompression sickness, such as paraplegia due to spinal cord involvement.
So, a mixed picture sometimes.
Yes. While sudden onset immediately upon surfacing strongly suggests AGE, a more delayed or complex neurological picture could represent combined AGE and DCS, or just severe DCS.
You mentioned earlier that AGE signs can sometimes clear up initially only to return later.
This is a vital clinical characteristic to be aware of, reinforcing that delayed deterioration phenomenon we discussed. In some patients with cerebral AGE, the initial neurological signs might improve spontaneously, perhaps as bubbles redistribute, or show significant improvement after initial hyperbaric therapy.
But then they get worse again.
They can. These symptoms can then recur or worsen after a period of minutes to several hours. This delayed worsening is often attributed to the development of cerebral edema, inflammation, or other secondary injury mechanisms we discussed. It highlights the dynamic nature of the injury process. Don't be falsely reassured by early improvement.
What about the timing of symptom onset for gas embolism due to hydrogen peroxide ingestion? Is that also rapid?
No, that's a notable exception to the rule of rapid onset. Gas embolism due to hydrogen peroxide ingestion can have a considerably delayed presentation.
How delayed?
Data reported in the source by King shows that in a series of 126 cases, only 74% were symptomatic within 1 hour of ingestion. 86% developed symptoms within 6 hours. Critically, symptoms could develop up to 24 hours after ingestion, and in 2 reported cases, symptoms even developed greater than 24 hours later.
Wow, that's a huge window. Makes diagnosis harder.
It certainly does, especially if the history of ingestion isn't immediately available or clear.
What are the supporting features for diagnosis that can help us increase our confidence in a suspected case?
Beyond the clinical signs, several features can strongly support a diagnosis of gas embolism. In a diving context, clear evidence of a rapid or breath hold ascent history is a major clue.
The mechanism.
Yes. Evidence of pulmonary barotrauma on physical examination, like subcutaneous emphysema or imaging, is also supportive, though its absence does not rule out AGE. Crucially, direct visual observation of intravascular gas.
Singing the bubbles.
Using techniques like Doppler ultrasound over the heart or neck vessels, or direct observation or aspiration of gas from a central venous line or during a procedure, provides definitive evidence. Finally, the circumstances surrounding the event are paramount. Was there a recent high-risk surgical procedure where air entrainment is possible, a known intravascular injection, or a significant ambient pressure change? These circumstances, combined with a consistent clinical picture, form the basis of a presumptive diagnosis.
Where do imaging considerations fit into the diagnostic process? Can we simply order a scan to confirm gas embolism?
This is an absolutely critical point, especially for specialist clinicians who might instinctively reach for imaging. While imaging studies such as computed tomography or CT or magnetic resonance imaging or MRI can sometimes reveal intravascular error, It is absolutely essential to understand their significant limitations in confirming the diagnosis of gas embolism.
They often miss it.
Yes. Brain imaging, specifically CT or MRI of the brain, often appears completely normal, even in the presence of severe, clinically obvious neurological abnormalities caused by arterial gas embolism.
So imaging has low sensitivity for detecting the clinically significant gas.
Precisely. The bubbles causing microvascular and cellular injury may be too small or transient to be consistently visualized on standard imaging. Furthermore, in divers with AGE, signs or symptoms of underlying pulmonary barotrauma are present in only approximately 50% of cases.
So you can't rely on seeing barotrauma on a scan either.
Correct. Therefore, the absence of radiologic findings suggestive of pulmonary barotrauma on a chest X-ray or CT scan cannot be used to exclude the diagnosis of arterial gas embolism. Relying on imaging to confirm the presence of gas or barotrauma will frequently lead to misdiagnoses or, perhaps worse, significant delays in appropriate treatment.
So imaging serves a purpose, but maybe not the one we initially think of.
Correct. Diagnostic imaging serves a useful clinical purpose only if there is clinical uncertainty, and you need to exclude other potential pathologies that might mimic the signs and symptoms of gas embolism but require completely different treatment.
Like a bleed or a clot stroke.
Exactly. If a patient presents with focal neurological deficits, imaging is important to rule out an intracranial hemorrhage, an ischemic stroke from a blood clot unrelated to gas, or a structural lesion like a tumor. Detecting any of these conditions would fundamentally alter your management plan.
So the only reason to delay definitive treatment for imaging is to exclude other problems.
Yes, exactly. According to the source, the only rationale for performing diagnostic imaging in a patient with suspected arterial gas embolism is specifically to exclude other acute intracranial pathology that might have similar clinical manifestations but necessitates different, potentially urgent, management strategies. Imaging is for ruling out mimics, not for confirming the gas itself.
We've covered the clinical picture. Let's pause here for our second micro-recap before moving into management.
Agreed.
Micro-recap 2. We've described the varied clinical presentations of gas embolism. For AGE, think sudden, severe neurological issues, loss of consciousness, stroke-like deficits. For significant VGE, think cardiopulmonary hypotension, pulmonary edema.
We highlighted the timing, typically very rapid onset, seconds to minutes, for diving AGE. But remember the potential for much longer delays, especially with hydrogen peroxide ingestion, up to 24 hours or even more, and the possible overlap with decompression sickness in divers.
We reviewed supporting features, a plausible mechanism, maybe signs of barotrauma, direct visualization of gas if you're lucky, but crucially, we stressed the major limitations of imaging, like CT and MRI.
Right. Brain imaging is often normal even with severe symptoms. Absence of visible gas or barotrauma doesn't rule out AGE.
So the main role for imaging in suspected AGE is really just to rule out other critical conditions that might look similar, like a hemorrhagic stroke. It's not for confirming the gas embolism itself.
Understanding these clinical nuances and the role or lack thereof of imaging is absolutely fundamental because it directly informs the critical, time-sensitive steps you need to take immediately for management, especially the decision regarding hyperbaric oxygen therapy.
So bringing the clinical picture together, what is the recommended approach to clinical management and recognition for hyperbaric treatment?
The most important principle, as clearly stated in the source, is that the presumptive diagnosis of arterial gas embolism is made primarily based on clinical criteria. You don't wait for imaging to confirm it.
What are the essential components of those key clinical criteria?
They include the combination of a plausible mechanism for gas entry and a consistent clinical presentation. A plausible mechanism involves scenarios like a recent rapid or breath-hold ascent while breathing compressed gas, known lung pathology predisposing to barotrauma, visual observation of intravascular air entry during a procedure.
Seeing air in a line, for example.
Exactly. Or ingestion of hydrogen peroxide or a surgical site positioned above the heart where venous pressure is subatmospheric. This mechanism must be present in conjunction with clinical signs and symptoms consistent with gas embolism, such as sudden neurological changes or acute cardiopulmonary compromise.
This reinforces the message about imaging, doesn't it?
Absolutely. It bears repeating. Diagnostic imaging, whether computed tomography or magnetic resonance imaging, is explicitly and emphatically stated as not necessary to confirm the diagnosis of AGE.
It's just not sensitive enough.
Its sensitivity and specificity for detecting the relevant gas bubbles are low, and critically, Finding or not finding gas on a scan does not and should not alter the immediate management decision when AGE is strongly suspected based on a compelling mechanism and clinical presentation.
And relying on imaging can be detrimental.
Yes. Performing brain imaging when there is a high clinical suspicion of AGE based on mechanism and presentation usually results in a significant and potentially harmful delay in initiating the appropriate definitive treatment, which is hyperbaric oxygen therapy. Time is critical here.
So imaging only serves a purpose in very specific situations.
Precisely. Imaging serves a useful clinical purpose only if you are clinically uncertain and need to exclude other serious pathologies that could present with similar signs and symptoms but require different urgent treatment.
Ruling out the mimics.
Ruling out the mimics. For example, if you're considering stroke mimics like a hemorrhagic stroke or a primary ischemic stroke due to a clot from a non-gas source, imaging is essential to differentiate. The only validated rationale for performing diagnostic imaging in a patient with suspected arterial gas embolism is solely to exclude other conditions that might manifest similarly but require alternative management.
Given the rapid onset, complexity, and need for specialized treatment, who should clinicians consult when faced with a suspected case?
Consultation with an undersea and hyperbaric medicine specialist is highly recommended and indeed crucial when dealing with any suspected or confirmed case of gas embolism, particularly in anomalous, complex, or severe cases.
Get the experts involved early.
Absolutely. Their expertise in diagnosing, managing, and coordinating transport for hyperbaric treatment is invaluable.
All right, let's get into the first aid immediate treatment. What are the non-negotiable initial steps?
The immediate treatment before hyperbaric therapy can be initiated consists of several critical first aid steps. These are ensuring a clear airway and maintaining adequate ventilation, maintaining adequate blood pressure, and administering the highest feasible concentration of oxygen, ideally 100% inspired oxygen.
ABCs plus high-flow O2.
Essentially, yes. These are the ABCs plus oxygen specifically targeted to the potential injury.
Why is maintaining blood pressure so important in this context?
Maintaining adequate blood pressure is vital because hypotension, or low blood pressure, can significantly worsen the injury, particularly in the brain. Cerebral blood flow is dependent on adequate perfusion pressure.
Makes sense.
If gas bubbles are already compromising blood flow by obstructing vessels, concurrent hypotension will severely exacerbate the resulting ischemia. Therefore, hypotension should be aggressively treated to maintain cerebral perfusion pressure.
And the high concentration oxygen, how does that help immediately?
Administering a high concentration of oxygen provides immediate benefits in two ways. First, it ensures maximum oxygen delivery to tissues that might be experiencing reduced blood flow due to vascular obstruction by bubbles, thus minimizing ischemic damage.
Helps the starving tissues.
Right. Second, and specifically relevant to bubble dynamics, breathing 100% oxygen at atmospheric pressure increases the partial pressure gradient for nitrogen, or other inert gases, to diffuse out of the gas bubble and into the surrounding blood, where it can be transported to the lungs and exhaled. This helps to reduce the size of the bubble even before hyperbaric compression.
Starts washing out the nitrogen.
Exactly.
Is there any gas that must be absolutely avoided?
Yes, this is a critical point, particularly in anesthetized patients. Nitrous oxide and uro must be absolutely avoided if gas embolism is suspected.
Laughing gas is bad here.
Very bad. Nitrous oxide is highly soluble in blood and tissues and diffuses rapidly into any existing gas bubble. Because it diffuses into the bubble much faster than nitrogen or other inert gases can diffuse out, it causes the bubble volume to rapidly and significantly increase.
Makes the bubbles bigger.
Yes, worsening obstruction and injury. Therefore, if gas embolism is suspected in an anesthetized patient, nitrous oxide should immediately be discontinued and not included in the anesthetic regimen.
If a patient is intubated and ventilated, delivering 100% oxygen is straightforward.
Yes, if a patient is intubated and receiving mechanical ventilation, then delivering a fractional inspired oxygen concentration of 1.00 or 100% oxygen is easily and reliably accomplished.
What about patient positioning? I recall hearing about specific positions, like head down.
This is an area where recommendations have changed based on better understanding of the pathophysiology. The head-down position, or steep Trendelenburg position, was formerly recommended for the initial treatment of patients with AG.
Why was that?
The theoretical rationale was that it might help minimize further cerebral embolization based on the buoyancy of gas bubbles, though buoyancy has limited effect in complex high-flow arterial systems and potentially cause some bubble shrinkage due to increased hydrostatic pressure on the head. Some anecdotal reports seem to support its use.
But it's not recommended anymore.
Correct. Based on current understanding and evidence, the head-down position is no longer recommended. The potential benefits regarding bubble redistribution or size reduction are marginal or theoretical in reality, while the head-down position has significant downsides. Most importantly, it can worsen cerebral edema, which, as we discussed, is a major contributor to delayed neurological deterioration in AG. It can also complicate airway management and ventilation.
So what is the current recommended positioning for a patient with suspected AG?
The recommended first aid position for a conscious patient with suspected AGE is the supine position, flat on their back. This maximizes airway protection and facilitates airway management should the patient's consciousness deteriorate. For an unconscious patient, placing them in the recovery position or lateral decubitus position is recommended if practicable, as this helps protect the airway from aspiration.
And during transportation to a hyperbaric facility?
Maintaining a supine position during evacuation and transportation is recommended if practicable, again primarily for reasons of airway control and management. The source mentions reports of re-embolization by bubbles previously sequestered in an anatomic trap, such as potentially in the pulmonary veins, occurring after positional change from supine to upright.
So changing position could be risky.
It highlights a theoretical risk associated with changes in posture, another reason to favor keeping them supine if possible.
Are there specific considerations for patients who develop AGE while on cardiopulmonary bypass?
Yes, this is a unique scenario. For patients experiencing AG while on cardiopulmonary bypass during cardiac surgery, immediate retrograde cerebral perfusion has been used as a rescue maneuver.
Perfusing backwards?
Yes. This involves perfusing the brain backwards through the jugular veins, aiming to flush gas bubbles out of the cerebral circulation.
Okay, we've covered the immediate first aid. Now, let's talk about the definitive treatment. Hyperbaric oxygen, HBO2 therapy. Why is this considered the mainstay of treatment?
Hyperbaric oxygen therapy remains the definitive treatment for arterial gas embolism. Its effectiveness stems from multiple synergistic mechanisms that directly address the pathophysiology.
Let's break down these mechanisms.
The first and most immediate mechanism is the effect of higher ambient pressure, directly related to Boyle's law. By placing the patient in a hyperbaric chamber and increasing the ambient pressure, you physically reduce the volume of the gas bubble.
Crushing the bubble.
Essentially. At 2.82 atmospheres absolute, equivalent to a depth of 60 feet of seawater, a gas bubble will be compressed to approximately one-third of its original volume at the surface, 1 ATA. This reduction in size can be critical in relieving mechanical obstruction in blood vessels, potentially allowing blood flow to resume past the smaller bubble or enabling smaller bubbles to pass through critical microvascular beds.
Makes sense. What's the second mechanism?
The second key mechanism relates to Henry's law, which governs the solubility of gases in liquids. Henry's law states that the amount of gas dissolved in a liquid is directly proportional to the partial pressure of that gas above the liquid.
Okay.
When a patient breathes 100% oxygen at an elevated ambient pressure, the partial pressure of oxygen in their blood and tissues increases dramatically. This creates a very steep partial pressure gradient for inert gas, like nitrogen if air was the embolic agent, to diffuse out of the gas bubble and into the surrounding plasma and tissues.
Driving the nitrogen out.
Exactly. Where it is then transported to the lungs and exhaled. This process effectively washes out the inert gas from the bubble, causing the bubble to shrink and eventually resolve. Simultaneously, the very high dissolved oxygen concentration in the blood under hyperbaric conditions can sustain tissue oxygenation even if blood flow is partially compromised by bubbles.
So, smaller bubble and better oxygen delivery. And the third mechanism?
The third major mechanism involves the pharmacological effects of hyperbaric hyperoxia, the effects of very high partial pressures of oxygen on cell function. These effects go beyond just bubble reduction and improved oxygen delivery.
What kind of effects?
Critically, hyperbaric oxygen inhibits the adhesion of leukocytes, particularly neutrophils, to the damaged vascular endothelium. As we discussed earlier, neutrophil adhesion and accumulation are key contributors to the microvascular inflammatory injury and delayed blood flow reduction seen after bubble contact.
So it reduces the inflammation.
By reducing this leukocyte adhesion, HBO2 helps to attenuate the inflammatory cascade, protect the microvasculature, and potentially preserve blood flow beyond just the effect of bubble size reduction. It's an anti-inflammatory effect.
Has the clinical effectiveness of HBR2 been shown in studies?
Yes. While large randomized controlled trials are difficult to conduct for such an acute and relatively rare emergency, retrospective reviews of published cases of arterial gas embolism consistently show significantly superior outcomes,
Better recovery, lower mortality.
including higher rates of complete recovery and lower mortality in patients who receive hyperbaric oxygen therapy compared to those treated with supportive care alone. The difference is often quite stark.
And timing matters.
Absolutely. A short interval between the gas embolism occurrence and the initiation of recompression treatment is consistently associated with a higher probability of a good neurological outcome. The sooner you get the patient into the chamber, the better the chances of mitigating irreversible damage.
But what if there's a delay? Is it too late?
It's important not to despair, even with delays. Clinical response and good outcomes have been observed even after 24 hours or more from the incident. So, while rapid transport and treatment are the goal, a delayed presentation should not automatically lead to withholding HBO2 therapy, as there can still be significant benefit.
What about asymptomatic venous gas embolism? Does that require HBO2?
No. Hyperbaric oxygen therapy is generally not required for asymptomatic venous gas embolism. Small volumes of VGE are common, particularly after diving, and are usually efficiently filtered by the pulmonary capillaries without causing clinical issues.
But it might help with symptomatic VGE.
Yes, the source notes that HBO2 can produce clinical improvement in the specific manifestation of secondary pulmonary edema that can occur following a large venous gas embolism, even if the primary target is often AGE.
What about patients who seem to recover quickly on their own? Should they still receive HBO2?
Yes, this is a crucial point based on the risk of delayed deterioration we talked about. Because of the well-recognized tendency for patients with AGE, particularly cerebral AGE, to deteriorate clinically after apparent initial recovery.
Even if they look okay initially.
Even then, early hyperbaric oxygen therapy is strongly recommended even for patients who appear to have spontaneously recovered from their initial symptoms. The underlying microvascular and cellular injury may still be progressing, and HBO2 can help mitigate this secondary injury.
You mentioned earlier that brain imaging often doesn't show bubbles. Does the absence of visible gas on a scan mean HBO2 won't be effective?
Absolutely not. As we've discussed, brain CT or MRI are insensitive tools for detecting the clinically relevant gas bubbles, especially microbubbles. Furthermore, the mechanisms of HBO2's benefit extend beyond just shrinking visible bubbles to include reducing inflammation and improving microvascular blood flow.
So it works even if you can't see the bubble.
Precisely. Therefore, timely administration of hyperbaric oxygen therapy usually causes clinical improvement even in the complete absence of demonstrable gas bubbles on imaging. The decision for HBO2 should be based on clinical suspicion, not imaging findings.
We've covered the immediate management and the rationale for HBO2 in depth. That was a comprehensive overview.
It's vital to thoroughly understand these core principles before moving on to specific scenarios and adjunctive treatments.
Let's consolidate what we've discussed so far regarding management.
Agreed.
Mega recap 1. We established that the presumptive diagnosis of arterial gas embolism is primarily clinical based on a plausible mechanism and consistent presentation. Forget waiting for imaging confirmation.
Right. Imaging is insensitive for gas itself and mainly serves to rule out mimics like hemorrhage. Delaying treatment for imaging is usually the wrong move.
Then the immediate first aid. ABCs. Manage blood pressure aggressively to maintain perfusion, give 100% oxygen to shrink bubbles and oxygenate tissue, and crucially, absolutely avoid nitrous oxide.
Positioning is key too. Supine or recovery position is recommended now. The old head-down Trendelenburg position is out because it can worsen cerebral edema.
Then the definitive treatment, hyperbaric oxygen. We covered its powerful, multifaceted mechanisms, Boyle's law, shrinking the bubble with pressure, Henry's law, washing out inert gas with high oxygen, and the crucial pharmacological effects of hyperoxia, especially reducing leukocyte adhesion and inflammation.
And the evidence, though retrospective, strongly supports HBO2, showing better outcomes and lower mortality. Timing is critical, sooner is better, but benefit can still occur even with delays.
And remember, HBO2 is recommended even for patients who seem to recover initially due to that risk of delayed deterioration, and it often works even if you can't see bubbles on a scan because of those microvascular and anti-inflammatory effects.
That covers the fundamental principles of diagnosis and immediate care. Now let's consider some specific clinical challenges, additional therapies, and what we can expect regarding outcomes.
Let's talk about managing coexisting conditions, particularly pneumothorax, which seems like a significant potential complication in patients with pulmonary barotrauma.
Yes, pneumothorax is a major concern in patients whose AGE is caused by pulmonary barotrauma, such as divers or patients on ventilators who experience lung rupture. These patients are at risk of developing a pneumothorax, which is air in the pleural space,
A collapsed lung.
or even a tension pneumothorax, where the air builds up and collapses the lung and shifts mediastinal structures during the decompression phase in the hyperbaric chamber. This happens because, again, due to Boyle's law, any free gas trapped in the pleural space will expand as the ambient pressure decreases during the ascent back to surface pressure after treatment depth.
So how is that risk managed?
To address this risk, chest radiography or ultrasound is justified and indeed highly recommended prior to initiating hyperbaric oxygen therapy in patients with suspected pulmonary barotrauma as the cause of their AGE.
Check for it beforehand.
Yes. If a pneumothorax is identified, placement of a chest tube to drain the air should be strongly considered. The source specifically recommends that chest tube placement should be considered and is recommended for patients being treated in a monoplace chamber.
Why the emphasis on a monoplace chamber for chest tubes?
A monoplace chamber is a single-person chamber, and access to the patient inside is significantly limited once the chamber is pressurized. Managing a developing tension pneumothorax within a monoplace chamber without a pre-placed chest tube is extremely challenging and potentially impossible without aborting the treatment.
So it's a safety issue for monoplace.
It's a critical safety measure before starting HBO2 in a monoplace. Proactively placing a chest tube in a patient with a high risk of pneumothorax is vital.
What if they are treated in a multiplace chamber, which is larger and allows medical personnel inside under pressure?
For multiplace chamber treatment, careful monitoring of the patient for signs of pneumothorax is essential if a chest tube cannot be placed or is not feasible beforehand. Multiplace chambers have the advantage of allowing medical attendants to be inside with the patient under pressure.
So you can intervene if needed.
Exactly.
Yeah.
And importantly, they offer the capacity and equipment for thoracostomy tube placement within the chamber if a pneumothorax develops during the treatment run.
What about pneumomediastinum, air around the heart?
Coexisting pneumomediastinum, which is air trapped in the mediastinum around the heart and airways, is less concerning in this context. It generally resolves with hyperbaric oxygen therapy itself and typically does not require any specific additional intervention like a chest tube.
Let's discuss the actual hyperbaric treatment protocols. What pressures and standard tables are typically used?
In the past, immediate recompression to very high pressures, up to 6 atmospheres absolute, which is equivalent to a depth of 165 feet of seawater, was sometimes recommended.
Going really deep.
Yes, with the theoretical goal of achieving maximal bubble reduction and enhancing bubble redistribution.
Is that still the standard approach?
No, that high initial pressure spike is generally no longer the standard. Several factors led to this change. First, the proportional bubble volume change diminishes significantly at progressively higher pressures. As we noted, going from 1 ATA to 2 ATA halves the volume, but the relative reduction becomes less pronounced with further pressure increases.
Diminishing returns.
Right. Second, and critically, compression beyond 2.82 atmospheres absolute typically requires the patient to switch from breathing 100% oxygen to a gas mixture containing inert gas, such as air or heliox. Breathing an inert gas mixture at depth reduces the partial pressure gradient, driving inert gas out of the bubble, making bubble resorption less efficient compared to breathing 100% oxygen at a slightly lower pressure.
So you lose some of the gas washout benefit.
Correct.
And has research supported this shift?
Yes. Neither studies of AGE in vivo in animal models nor retrospective human case reviews have provided clear evidence demonstrating consistently enhanced bubble redistribution or better overall outcomes with initial high-pressure spikes compared to treatment at more moderate pressures while breathing 100% oxygen.
So what is the recommended initial compression depth or pressure now?
Based on the current understanding and evidence, the recommended initial compression for arterial gas embolism is to 2.82 atmospheres absolute.
That's 60 feet of seawater.
Exactly, equivalent to 60 feet or 18 meters of seawater depth. At this depth, the patient breathes 100% oxygen. This depth provides significant bubble compression, down to about 1/3 the original volume, while allowing the patient to breathe 100% oxygen efficiently to maximize inert gas washout.
Using standard treatment tables.
Yes, this treatment is typically delivered using standardized protocols such as the United States Navy Treatment Table 6 or other equivalent hyperbaric treatment schedules used by different navies and commercial diving operations.
Are shorter versions of these tables sometimes used?
Yes. Shorter hyperbaric treatment tables that are specifically designed for use in monoplace chambers have been employed successfully in many hyperbaric medicine facilities.
What if the patient's clinical response is not optimal after the initial treatment? Can the tables be adjusted?
Yes, in facilities with the necessary expertise and specialized hardware, significant modifications of established HBO2 treatment regimens can be utilized if the initial clinical response is suboptimal or incomplete.
Like going deeper or staying longer?
Options can include deeper recompression, perhaps to 3.0 ATA, or slightly deeper while still breathing 100% oxygen if tolerance permits, or expansion of the treatment table duration to provide longer exposure to hyperbaric oxygen. These modifications are implemented based on the clinical judgment of the hyperbaric specialist and the resources of the facility.
Moving on to repetitive treatments. Are multiple HBO2 sessions often needed for AG?
Yes, administration of repetitive hyperbaric oxygen treatments is recommended for arterial gas embolism. The goal is to continue treatments until there is no further discernible stepwise improvement in the patient's clinical condition.
So you treat until they plateau?
Essentially, yes.
Yeah.
Until no further stepwise improvement is seen.
How many treatments does that typically involve?
Clinically significant improvement is often observed relatively early, sometimes after no more than 1 to 2 hyperbaric treatments. However, in some cases, particularly those with severe initial presentation or slower recovery, repetitive treatments might be required, potentially up to 5 to 10 sessions, to achieve maximal recovery.
Let's revisit the challenging pulmonary barotrauma and cerebral AG scenarios in patients with underlying lung disease. We discussed the pneumothorax risk. Are there other management challenges?
Yes. Managing cerebral AGE in patients with underlying pulmonary pathology like bullae, emphysema, or severe asthma poses a difficult clinical scenario. The definitive treatment, recompression with HBO2, inherently re-exposes the patient with a predisposition to lung rupture, to the risk of further pulmonary barotrauma during the pressure changes.
Especially during the ascent phase of the treatment.
Exactly, especially during the decompression phase at the end of the treatment.
How is this risk balanced against the need for HBO2?
It requires a careful, individualized assessment of the risks versus the potential benefits of hyperbaric oxygen treatment for each patient. For a severely affected patient with significant neurological compromise from AGE, the potential benefits of HBO2 in preventing permanent disability or death typically outweigh the risk of exacerbating lung injury.
So you likely still treat?
Generally, yes. The approach would generally be to proceed with HBO2, potentially implementing variations to the standard protocol to minimize barotrauma risk during ascent. These variations might include using lower initial treatment pressures, perhaps 2.4 ATA instead of 2.82 ATA, or significantly prolonging the decompression times from treatment depth to allow any potential free gas more time to escape the lungs safely.
Given that emergency hyperbaric facilities are not available everywhere, how are decisions about transportation made for patients with suspected gas embolism?
Because emergency hyperbaric oxygen facilities are not universally distributed, decisions regarding the transportation of patients with suspected gas embolism, whether they have relatively minimal symptoms or are critically ill, should ideally always be made in consultation with an undersea and hyperbaric medicine specialist.
Call the expert first.
Yes, they can help assess the severity of the patient's condition, the potential benefits of prompt hyperbaric treatment, the risks of transport, things like potential worsening due to altitude changes in air transport, delays, and the capabilities of the receiving facility.
Does the time elapsed since the incident affect the urgency of transportation for treatment?
According to consensus guidelines, primarily related to decompression sickness, untreated mild symptoms and signs due to decompression illness are considered unlikely to progress significantly after 24 hours from the completion of diving.
But does that apply to AGE?
That's the uncertainty. It is explicitly stated that whether this principle applies equally to isolated arterial gas embolism that is unrelated to diving is unknown. And as we highlighted earlier, symptom onset from gas embolism due to hydrogen peroxide ingestion is often delayed, meaning the time window might be longer in that specific scenario.
Right. The source also mentions something about portal venous gas.
Yes, it includes a finding that portal venous gas on imaging was experienced by 27 of 49 patients with portal venous gas as the main finding in experienced gastrointestinal bleeding cases. While this seems tangential, it serves as an unusual example of intravascular gas seen in a different context, reminding us of the diverse ways gas can appear in the circulation, potentially relevant if considering unexpected sources of embolism.
Let's move to adjunctive therapy. Besides oxygen and hyperbaric treatment, are there other medications or interventions that might be helpful?
Yes, there are a number of adjunctive therapies that have been considered, though it's important to note that there is a lack of large, systematic human studies for critically ill patients with AGE treated with these therapies in combination with optimal management, including normotension and avoidance of hypocapnia.
So the evidence might be limited for some.
For many, yes. The source references more detailed reviews on this topic. However, based on an evidence-based review summary provided within the source material, specific adjunctive therapies are assigned recommendations with a class and level of evidence.
Let me go through that list and understand the meaning of the class and level recommendations. Can you quickly recap those?
Sure. Class 1 means strong evidence agreement. Benefit outweighs risk. Class 2A means reasonable evidence. Benefit likely outweighs risk. Class 2B means weaker evidence. Benefit might be marginal compared to risk. Class 3 means evidence suggests no benefit or potential harm, recommended against. Level A is high-quality evidence, RCTs. Level B is moderate quality, and Level C is consensus opinion, case studies, or standard of care.
Armed with that understanding, let's go through the specific recommendations from the source.
Okay. Oxygen administered as a first aid measure has a formal recommendation of Class 1, Level C, strongly recommended based on consensus.
Standard first aid.
Right. Lidocaine, which has theoretical neuroprotective properties, has a recommendation of Class 2A, Level B, reasonable benefit, moderate evidence. Worth considering.
Okay. Aspirin.
Aspirin, an antiplatelet agent, is recommended as Class 2B, Level C, benefit less established, lower evidence. Non-steroidal anti-inflammatory drugs, or NSAIDs, also Class 2B, Level C, similar rationale.
Anticoagulants.
Anticoagulants, aiming to prevent secondary clotting, are recommended as Class 2B, Level C.
What about steroids, often used for brain swelling?
Corticosteroids are recommended as Class 3, Level C. This is a recommendation against their use.
Why against?
Likely, based on expert consensus and concerns about potential harm, perhaps impaired healing or infection risk, outweighing any theoretical benefit in this specific context of AGE.
Interesting. What about intravenous fluids?
Careful selection here. Dextrose 5% in water is Class 3, Level C, recommended against.
Why D5W is bad?
Because hypotonic solutions like D5W can worsen cerebral edema and potentially cause hyperglycemia, which itself is detrimental to neurological outcome. Isotonic crystalloid solutions, like normal saline, have a recommendation of Class 2B, Level C, less likely to exacerbate edema, okay for volume if needed. Colloid solutions, like albumin, also Class 2B, Level C, can help with volume, but specific benefit over crystalloids isn't strongly established here.
So careful selection of fluid type is important to avoid worsening brain swelling.
Precisely. And importantly, hyperglycemia, or high blood sugar, should be actively treated if present, as it is known to worsen central nervous system injury and various forms of ischemic brain injury.
You noted earlier that aggressive fluid therapy might not be needed for isolated AGE, but what if it's combined with decompression sickness?
That's an important clinical distinction. While isolated AGE generally does not necessitate aggressive fluid therapy beyond maintaining normotension, patients with accompanying decompression sickness, particularly the more severe forms, may present with significant hemoconcentration.
So they need fluids then?
Yes. In these cases, aggressive intravenous fluid resuscitation with isotonic solutions is appropriate and required to restore circulating volume and improve tissue perfusion.
For patients who are immobilized for an extended period due to neurological injury, what about preventing blood clots in the veins? VTE prophylaxis.
Prophylaxis against venous thromboembolism, or VTE, which includes deep vein thrombosis and pulmonary embolism, is a critical consideration for any patient with neurological injury causing immobility for 24 hours or greater. Low molecular weight heparin is specifically recommended for this purpose.
What's the evidence level?
This carries a strong recommendation of Class 1, Level A. This is significant because it's a Class 1 recommendation based on Level A evidence, high-quality data showing clear benefit, making it a standard of care in this situation.
Any temperature management recommendations?
Aggressive treatment of fever is recommended. Hyperthermia, or elevated body temperature, is known to adversely affect neurological outcome in many types of brain injury, including stroke, and should be avoided and treated promptly.
What about therapeutic hypothermia, cooling the patient down?
Therapeutic hypothermia, or induced cooling, has a plausible theoretical rationale given its neuroprotective effects in other forms of brain injury, such as after cardiac arrest. However, it is not yet considered standard of care for gas embolism.
Still experimental here.
Considered experimental or emerging. The source mentions that it has been reported in specific case reports for AGE occurring after lung biopsy and has been used in conjunction with hyperbaric oxygen therapy after scuba diving. But currently, it is not a routine intervention.
Let's look at outcome. What does the available data tell us about prognosis and recovery rates with and without HbO2?
While large randomized controlled studies are lacking, retrospective reviews provide valuable insight into outcomes.
What did the Dutka review of many cases show?
The Dutka review, which analyzed 656 published cases of AGE from various causes, provided compelling evidence for the benefit of HbO2. It found that full recovery occurred in 78% of individuals who received HbO2 therapy, compared to only 56% of those who were treated without hyperbaric oxygen.
That's a big difference in recovery. What about mortality?
Even more dramatically, mortality rates were significantly lower in the HbO2 group at 5%, compared to a very high 42% in those who did not receive recompression treatment.
Wow, 42% mortality without HbO2. That's huge.
It really underscores the impact. This massive reduction in mortality and significant increase in full recovery rate provides strong support for HbO2 as the definitive treatment.
What about outcomes specifically in iatrogenic AGE cases, those caused by medical procedures?
A review by Benson, looking specifically at 19 patients with iatrogenic AGE treated with hyperbaric oxygen therapy, provides more granular data on recovery trajectory. After the first treatment, looking at 5 patients specifically, about a quarter had resolved symptoms, some improved, some didn't change.
And overall outcomes in that group?
Looking at the overall outcomes for the 19 patients in Benson series, 8 patients, 42%, achieved complete recovery. 6 patients, 32%, had partial recovery, and tragically, 5 patients, 26%, died, primarily from complications related to the gas embolism.
Is there evidence linking the time to treatment directly to the outcome?
Yes, the Beaver series, which reported on 45 patients with iatrogenic AGE treated with HbO2 at a single institution, found a statistically significant relationship. In this series, a good neurological outcome was achieved in 60% of patients.
And what predicted that good outcome?
The only statistically significant factor predictive of a good outcome in this specific cohort was the time from the incident to the initiation of HbO2 treatment. Patients who had a good outcome had a mean time to treatment of 8.8 hours, significantly shorter than the 16.5 hours mean time for those with poorer outcomes.
So again, time is brain, essentially.
It strongly reinforces the clinical imperative for rapid diagnosis and transport for HbO2. However, it's also important to remember that treatment can still be beneficial even when delayed.
Examples of late recovery.
Benson's series included one patient who eventually achieved complete recovery despite a 28-hour delay from incident to HbO2. The source also mentions a vivid case report of a 51-year-old diver who was deeply comatose for 6 days after a 30-meter dive in AGE, received HbO2 late, and was reported to have a functional life 1 year later.
So don't give up hope even if treatment is delayed.
Exactly. These cases highlight that recovery can still occur even in severe delayed presentations, though earlier is definitely better.
Does bubble persistence correlate with outcome or need for continued treatment?
Gas bubbles are known to persist in some tissues for several days, despite hyperbaric oxygen treatment. While the Beaver study showed the predictive value of early treatment, reports also note that failure to recover has been associated with situations where HbO2 treatments were initiated days after the injury, potentially because secondary injury pathways have become irreversible.
Is HbO2 equally effective for gas embolism from all causes?
The source notes that HbO2 may be less effective for the treatment of gas embolism, specifically from hydrogen peroxide ingestion, compared to other mechanisms.
Why might that be?
The mechanism of oxygen generation might lead to different bubble dynamics or secondary injuries. While treatments are still indicated, the outcome profile in the King series that included these cases, 13 full recoveries, 10 with residual symptoms, or death out of 23 treated with HbO2, suggests a potentially different prognosis compared to, say, diving-related AGE.
Let's formalize the evidence base for HbO2. What is the official recommendation?
The use of hyperbaric oxygen therapy for both arterial gas embolism and symptomatic venous gas embolism carries a formal recommendation from the American Heart Association, or AHA. It is classified as a Class 1 recommendation, with a level of evidence classified as Level C.
So, Class 1, Level C. Strong recommendation based on expert consensus.
Correct. Class 1 signifies strong evidence or general agreement that the treatment is beneficial and effective, with benefits clearly outweighing risks. Level C indicates that this recommendation is based on expert consensus opinion, case studies, or standard of care due to the absence of higher quality evidence like large randomized controlled trials, which are difficult to conduct for this rare and acute emergency.
What about utilization review? How many treatments before review?
Utilization review, a process to evaluate the appropriateness and necessity of healthcare services, is typically recommended after a patient has received 10 hyperbaric treatments for this condition.
Finally, let's consider the cost impact. Is hyperbaric oxygen therapy considered a cost-effective treatment for air embolism?
Yes. Despite the potentially high cost of individual hyperbaric treatment sessions and the need for potentially multiple sessions, the source emphasizes that hyperbaric oxygen therapy is considered cost-effective in the overall management of air embolism from any cause.
Why is that?
Because its ability to significantly decrease the high mortality rates associated with untreated AGE and to prevent or significantly moderate permanent neurological damage results in much lower long-term care costs compared to the alternative scenario of higher mortality or severe lifelong disability requiring extensive care. The savings in lives and functional outcomes outweigh the treatment costs.
Now, let's thoroughly examine the comprehensive list of causes provided in Table 1 of the source. This table really drives home the point about how many different clinical contexts can lead to gas embolism.
It's an extensive list and a crucial resource for clinicians across many specialties. Let's organize it by the mechanisms we discussed. The first major category is direct arterial air entry, where gas enters the arterial circulation without necessarily starting as venous gas passing through a shunt or overwhelming the pulmonary filter.
Okay, what's in this category? The most well-known mechanism. Pulmonary barotrauma from ascent during compressed gas diving. The most well-known mechanism. Notably, pulmonary barotrauma can also occur during decompression from hyperbaric treatment itself in patients with underlying lung disease, as we discussed regarding pneumothorax risk. The most well-known mechanism. Mechanical ventilation, particularly with high pressures or in patients with lung pathology, can cause pulmonary barotrauma and lead to AGE. The most well-known mechanism. Chest trauma can cause direct lung injury and vascular communication. The most well-known mechanism. Placement of a chest tube can inadvertently introduce air into the pleura or lung vasculature if a vessel is punctured. Procedures involving the lung.
Yes. Needle biopsy of the lung carries a risk of puncturing airways and vessels. Bronchoscopy, particularly with biopsy or therapeutic interventions, can potentially introduce gas. A cardiopulmonary bypass accident during cardiac surgery is a recognized cause, often involving air in the circuit. Pulmonary vein rupture during rapid altitude exposure is listed, though less common than diving barotrauma. Accidental air injection directly into a radial artery catheter or any arterial line is a direct arterial route. And vascular air entry due to severe necrotizing pneumonia where the lung tissue is destroyed can create pathways for air from damaged airways to enter vessels.
That covers the mechanisms where air gets into the arterial side fairly directly, often via the lungs or a direct arterial injection. The second major category is venous gas embolism with secondary arterial entry via pulmonary circulation or intracardiac right-to-left shunt.
This encompasses the scenarios where gas starts in the veins and then makes its way to the arterial side, either by overwhelming the lung filter or through a PFOASD. Compressed gas diving is a cause of VGE due to tissue off-gassing, which can then lead to paradoxical AGE through a shunt. Rapid exposure to altitude can also cause VGE and potential paradoxical AG. Accidental intravenous injection of air, a significant iatrogenic cause.
Central lines are a big one here, right?
Absolutely. Hemodialysis catheter accidents, particularly during connection or disconnection, can allow air entry. Placement or disconnection of a central venous catheter is a classic and well-known source of iatrogenic VGE due to the subatmospheric pressure in large central veins during inspiration.
Other procedures.
Gastrointestinal procedures like endoscopy, esophageal ballooning, and endoscopic retrograde cholangiopancreatography, ERCP, can involve air insufflation and potential venous absorption or injury. Hydrogen peroxide ingestion, as we detailed, generates VGE and subsequent AG. Arthroscopy, typically of large joints, can involve fluid or gas insufflation and potential venous entry. Cardiopulmonary resuscitation, CPR, can, in rare instances, be associated with gas embolism, perhaps due to trauma or forceful ventilation. Percutaneous hepatic puncture for biopsy or drainage is listed.
And some less common but important ones.
Blowing air into the vagina during orogenital sex or after childbirth is a documented, though rare, cause of venous air entrainment, leading to VGE and sometimes fatal AG. Gastric barotrauma following hyperbaric oxygen therapy is noted. This is different from lung barotrauma. It involves expansion of gastric gas during decompression from HbO2, causing rupture and venous entry. Treatment of esophageal varices, often involving sclerotherapy or banding, can potentially involve injury to vessels and air entry. Atrial esophageal fistula following ablation for atrial fibrillation is a serious, though rare, complication where a connection forms between the esophagus and left atrium, allowing air from the esophagus to enter the arterial circulation directly. And finally, bubble contrast echocardiography. Using agitated saline to look for shunts demonstrates the potential pathway, though the bubbles used are designed to be filtered.
Table 1 also categorizes procedures where the risk is related to the surgical environment itself creating pressure gradients.
Yes, under the heading procedures in which the surgical site is under pressure, we see laparoscopy, where the abdomen is insufflated with gas under positive pressure, transurethral surgery with irrigating fluid under pressure, vitrectomy, eye surgery involving infusion, endoscopic vein harvesting using CO2 insufflation, hysteroscopy involving fluid distension of the uterus.
So the pressure drives the gas in.
That's the risk, the positive pressure applied to the surgical field, potentially driving gas or dissolved gas into open vessels. And finally, under the heading passive entry of air into surgical wounds situated above the level of the heart, such that venous pressure is subatmospheric, which utilizes the negative pressure gradient mechanism we discussed, the table lists a significant number of procedures, citing craniotomy as a classic and high-risk example.
Head above the heart.
Exactly. Also listed are cesarean section, radical perineal prostatectomy, retropubic prostatectomy, spine surgery, particularly in sitting or prone positions, hip replacement, liver resection, liver transplantation, even insertion of dental implants.
All situations where the surgical site might be higher than the heart.
Yes. In all these procedures, positioning the surgical site above the heart causes the venous pressure at the site to drop below atmospheric pressure, creating a suction effect that can draw air into any open veins.
That comprehensive table is a truly valuable overview, highlighting the importance of considering gas embolism across such a wide spectrum of clinical settings. Let's bring all this management information together by walking through the clinical algorithm presented in Figure 1 of the source.
Figure 1 provides a helpful flowchart for the clinical management of suspected arterial gas embolism, integrating many of the principles we've discussed into a step-by-step approach. It begins at the top with suspected AG.
And then it immediately directs to the initial treatment steps.
Yes. The first box, immediately under suspected AGE, outlines the absolutely critical initial management steps. Position patient, supine if conscious, lateral decubitus, or recovery position if unconscious. Manage airway, maintain blood pressure, treating hypotension aggressively, and administer high-inspired oxygen concentration, ideally 100%. These are the immediate first aid measures we've detailed.
Okay, initial stabilization. Then what?
From those initial steps, the flowchart introduces a branching decision point. Is there a preceding dive with evidence of pulmonary barotrauma? OR is monoplace chamber treatment planned.
Why these specific criteria at this point?
These criteria are specifically highlighting the increased risk of pneumothorax, as we discussed. If the answer to this question is yes,
High risk for pneumothorax.
the flowchart directs you to consider chest radiograph or ultrasound.
And if that imaging shows a pneumothorax?
If the result of chest imaging shows pneumothorax, is yes, the critical intervention is place chest tube, followed by hyperbaric oxygen. This reinforces the necessity of addressing the pneumothorax before or concurrent with HBO2 treatment, particularly when monoplace treatment is planned.
If the chest imaging shows no pneumothorax?
If the answer to chest imaging shows pneumothorax is no, the flowchart directs you to proceed directly to hyperbaric oxygen, as the immediate concern for managing attention pneumothorax during treatment is reduced.
What if the initial branching decision was no, meaning no preceding dive barotrauma evidence and no specific plan for monoplace treatment?
If the answer to preceding dive with evidence of pulmonary barotrauma or planned monoplace chamber treatment is no, you bypass the routine pre-HBO2 chest imaging check and proceed directly to hyperbaric oxygen.
Straight to the chamber.
Essentially, yes. While a pneumothorax is still possible depending on the cause, the immediate risk assessment doesn't mandate pre-treatment imaging in this specific branch of the algorithm, especially in a multiplace setting where in-chamber 2 placement is possible. After the hyperbaric oxygen box, regardless of the path taken to get there, the flowchart leads to a point to assess the patient's response. The question posed is, improved during recent HBO2 and clinically stable.
And the subsequent path depends on that assessment.
Exactly. If the answer is yes, the patient improved during the treatment and is now clinically stable, you proceed to the reassess box. At the reassessment point, you ask, signs, symptoms, resolved.
Fully recovered.
If the answer here is yes, meaning the patient has fully recovered, you stop HBO2. If the answer is no, meaning some symptoms or signs persist, you loop back to the reassess point after considering the need for further hyperbaric treatments.
What if they didn't improve or are unstable after the treatment?
If the answer to improved during recent HBO2 and clinically stable was no, meaning the patient did not improve or remains unstable, you also proceed to the reassess box, indicating the need for ongoing evaluation and consideration of further treatments based on the clinical picture.
So the flowchart visually reinforces the importance of repetitive treatments guided by clinical response, continuing until maximal improvement is achieved, and only stopping when no further progress is being made.
Precisely. And importantly, the flowchart includes a note stating that details of management steps are described in the text, referring back to all the nuanced points we've discussed about specific treatment table details, adjunctive therapies, managing hypotension, and other considerations.
This flowchart is an excellent visual summary of the clinical decision pathway. To help solidify understanding and apply this knowledge, let's integrate a board-style question example.
Okay, consider this clinical scenario that might appear on a board exam or in real practice. A 68-year-old male patient is undergoing an elective laparoscopic colectomy under general anesthesia. The surgical site is positioned slightly above the level of his heart. During a procedure, the anesthesiologist observes a sudden, precipitous drop in the end-tidal carbon dioxide reading, followed quickly by unexpected hypotension and cardiac dysrhythmias. Based on everything we've discussed from this source, what is the most likely diagnosis in this specific clinical setting? What is the primary mechanism that likely led to it? And what is the definitive initial treatment indicated?
Okay, so laparoscopic surgery means gas insufflation. Site above the heart means risk of passive entrainment. Sudden drop in EtCO2, hypotension, or arrhythmias. Sounds very much like gas embolism, most likely venous gas embolism initially, right?
Correct. VGE is highly probable in this setting. And the mechanism?
The mechanism is likely venous gas embolism resulting from the passive entrainment of insufflation gas or ambient air into open vessels at the surgical site due to the negative pressure gradient created by elevating the site above the heart, or potentially direct entry of insufflation gas under pressure into injured vessels.
Right.
Depending on the volume and rate, this could overwhelm the pulmonary filter or lead to paradoxical AGE if the patient has a patent foramen ovale or atrial septal defect, which would explain the neurological or cardiac symptoms more directly if they developed.
Excellent. Both passive entrainment and pressure-driven entry are plausible mechanisms in this surgical context. And given this likely diagnosis, what is the definitive initial treatment we've discussed extensively?
The definitive treatment, as per the Class 1 Level C recommendation from the AHA, is hyperbaric oxygen therapy. Immediate supportive measures like managing the airway, blood pressure, and administering 100% oxygen while arranging for HBO2 transport are critical first steps, and stop any nitrous oxide if it was being used.
Absolutely crucial point. That scenario effectively integrates mechanism, presentation, and management principles. Let's use some imagery example to help visualize some of the less obvious points we've discussed.
When thinking about the complex pathophysiology beyond mechanical blockage, try to visualize the microcirculation in the brain. Imagine a tiny gas bubble, maybe not even big enough to completely block the vessel. Now, picture that bubble making contact with the delicate, smooth inner lining of the blood vessel, the endothelium.
Just bumping along the wall.
Instead of just bouncing off, imagine that contact initiating a reaction. See the endothelial cells becoming irritated, potentially peeling away from their basement membrane. Then, picture those sticky neutrophils, those white blood cells, being drawn to the site of irritation, adhering to the damaged vessel wall and starting to accumulate,
Gunking up the works.
further narrowing the vessel and releasing inflammatory chemicals. This dynamic scene of damage and inflammation, triggered by the bubble even after it might have passed, helps illustrate why simply shrinking a bubble isn't the only benefit of HBO2 and why damage can progress over time, leading to delayed deterioration.
That visualization helps make the cellular mechanisms more tangible. For a space repetition cue, let's quickly revisit the core multimodal mechanisms of how hyperbaric oxygen therapy actually works, as this is central to the treatment.
Remember, HBO2 acts through three main pathways. 1, the pressure effect, Boyle's law. Simply increasing the ambient pressure physically compresses the gas bubble, reducing its volume and potentially relieving obstruction, shrinks the bubble.
2, the gas washout effect, Henry's law. Breathing 100% oxygen at high pressure creates a steep gradient that drives inert gas, like nitrogen, out of the bubble and into solution, causing the bubble to shrink and ultimately resolve. Drives the bad gas out.
3, The pharmacological effects of hyperoxia. High partial pressure of oxygen has beneficial effects beyond bubble dynamics, including inhibiting leukocyte adhesion to damaged endothelium, reducing inflammation, and potentially improving blood flow and tissue oxygenation at the microcirculatory level. Fights the inflammation.
It's the combination of these effects, pressure, oxygen gradient, and anti-inflammatory action that makes HBO2 so uniquely effective.
We've now thoroughly covered the management algorithm, specific scenarios like pneumothorax and underlying lung disease, the detailed list of adjunctive therapies and their evidence grading, the critical outcomes data highlighting the significant benefits and importance of timely HBO2, the extensive list of causes from Table 1 across diverse clinical settings, walked through the Figure 1 management flowchart, integrated a clinical scenario example, used visualization for the pathophysiology, and reinforced the core HBO2 mechanisms. That truly was a deep dive into the source material.
Indeed, we've parsed through the critical details of this complex condition.
Mega recap 2. We summarize the specifics of clinical management. Key point. Assess for and manage pneumothorax before or during HBO2, especially in monoplace chambers.
We detailed the HBO2 protocol standard is 2.82 ATA, 60 feet, on 100% oxygen, usually USN Table 6. We talked about why that's preferred over higher pressures and that protocols can be modified based on response.
Repetitive treatments are the norm, continuing until no further stepwise improvement. We touched on the challenges with underlying lung disease, careful risk-benefit assessment needed.
Absolutely. And consulting with hyperbaric specialists is crucial, especially for transport decisions. We went through the adjunctive therapies and their class-level recommendations. Remember, first aid oxygen is Class 1 Level C, VTE prophylaxis with LMWH for immobilized patients is Class 1 Level A, but steroids and D5W are Class 3, recommended against.
We reviewed the outcome data. HBO2 significantly reduces mortality and improves recovery based on large reviews like Dota's. Time to treatment is critical, Beaver series, but late treatment can still help, maybe less effective for hydrogen peroxide cases.
The formal recommendation for HBO2 is AHA Class 1 Level C. Strong recommendation, expert consensus level evidence.
We then covered the huge list of causes, from Table 1 direct arterial entry, barotrauma procedures, venous entry with secondary arterial passage, diving VGE plus PFO, central lines, GI procedures, H2O2, CPR, etc., procedures under pressure, laparoscopy, and passive entry in elevated surgical sites, craniotomy, spine surgery, C-section.
Finally, we walked through the Figure 1 flowchart summarizing the management pathway. Initial stabilization, pneumothorax check if indicated, prompt HBO2, and then assessment and reassessment guiding for the treatment. #outro.
We've reached the conclusion of this deep dive into the intricate world of air and gas embolism. Drawing extensively from the expert review by Moon and Mitchell, we've thoroughly explored the wide array of causes and the complex underlying mechanisms, the varied clinical presentations you might encounter, the non-negotiable immediate management steps, and the definitively established multifaceted role of hyperbaric oxygen therapy as the cornerstone of treatment, all grounded in the evidence presented in this authoritative source.
The critical takeaways for you, the specialist clinician, should be the paramount importance of maintaining a high index of clinical suspicion for gas embolism based on a plausible mechanism and clinical presentation. Remember the limitations of imaging. It's mainly to rule out mimics. Don't let it delay treatment.
Master those critical first aid steps, ABCs, O2, blood pressure, avoid N2O, correct positioning.
And recognize the multiple powerful benefits of hyperbaric oxygen pressure, gas washout, anti-inflammatory effects backed by evidence showing better outcomes. Understand the adjunctive therapies and their evidence levels. And know that timely treatment is best, but consult experts and consider treatment even if delayed.
Thinking about the complex microvascular, cellular, and inflammatory pathways of injury, we discussed the endothelial damage, the neutrophil adhesion, the intracellular signaling disruptions triggered by bubbles, and considering that damage can progress even after the bubbles are gone. What future adjunctive therapies, perhaps targeting these specific inflammatory or cellular injury pathways, might emerge to further improve outcomes, especially in delayed or severe cases where just shrinking bubbles isn't enough? That's a challenging question, but one worth contemplating as research continues.
This has been a comprehensive deep dive, aiming to equip you with the most crucial details and clinical context from this key source.
If you found this deep dive valuable and want to continue exploring the nuances, potential areas of uncertainty, and clinical application complexities of this critical topic, including aspects not explicitly detailed but implied by the mechanisms and evidence discussed, then
Type continue for further detail.